I'm Dr. Michael DeTola.
And I'm Megan Strong.
Florida fluoridates, then unfluoridates, and now refluoridates. That story and more on today's Chairside Live. Welcome to episode 29 of Chairside Live. Megan, how are you?
I'm doing well. How are you?
I'm doing great. Thank you for asking. We've got a great episode for you today. We've got an interesting case of the week from a doctor who I've grown to know particularly well over the years. That's me. I'm going to share one of my own cases with you, and it's an interesting tetracycline case, and I want to share with you what I've learned about how to treat these cases over the years. But before we get to that, let's go to a segment we call Viewer Mail. This week's letter comes from Dr. George Walker, and it's related to the case of the week where we showed the stock abutments versus the custom abutments. And he writes and he says, "Dear Mike, I'd like to share a tip for your audience. When your dental technician suggests using a custom abutment for an implant case, do it. I thought that the stock abutment would work, and it didn't. Listen to the tech." And so his advice is, instead of trying to do this yourself, if the technician you're working with suggests that you pay a little more and use a custom abutment, that it's probably the right thing to do. So thank you, George, for writing in and being read on the air. You have your choice of either a $1,000 lab credit or the picture. Megan, give me a number between 1 and 10.
8.
8. George, you won the picture. Congratulations. Not the $1,000 lab credit, but thank you for playing. And please continue to write in and give us your feedback and any suggestions that you might have. All right, now let's go ahead and go to Megan with the news.
A new study shows that people who maintain good oral health may have a lower risk of developing dementia later in life. Researchers at the University of California studied 5,500 elderly people over an 18-year period and found that those who reported brushing their teeth less than once a day were up to 65% more likely to develop dementia than those who brushed daily. Researchers are quick to point out that the study is limited. Neglecting oral hygiene may lead to dementia later in life, but there are many factors to consider.
How do you brush your teeth less than once a day?
Right. Wouldn't that just be
zero?
Brushing your teeth?
Not brushing your teeth. And does not brushing your teeth lead to dementia, or do demented people
not brush
their teeth?
Right.
That seems odd. And so it's one of those studies that seems a little bit confusing. The one thing I am glad for, the silver lining in this, is that it didn't come out and say that people who brush their teeth more often are more likely to get dementia, because the men of the United States do not need any more inducement to brush their teeth less than they're currently doing. I wonder if they're going to research flossing.
That would be a scary study right there.
That would be a scary one too, because we don't seem to be able to get adult males to change their habits and start flossing if they haven't started when they're really young. Thank you for that story. We'll see if anything more comes of that. You have anything else?
Yes. After 1 year of ending water fluoridation, a county in Florida will now fluoridate the water again. The county decided to reinstate the practice after a 6-to-1 vote by the Board of Commissioners. The county supplies water to some 700,000 people. The decision has sparked controversy, as some believe the move was about politics and power rather than science and public health. The county will have to pay about $185,000 to cover the cost of the change. Yet the commissioners predict that customers will not see an increase in their bill.
So that's funny. You know, most of the time when we see these fluoridation battles, it's trying to get fluoride added to a public water supply, which actually makes a lot of sense because, you know, kids in the middle class, kids that most of us see in our practices are either on chewable multivitamins with fluorides, or they're getting fluoride treatments in the office. You know, this is really aimed at a public water supply for kids who are going to be drinking tap water. Most middle class moms that I know would freak out if you suggested that their kids drink drink tap water. And so I feel like this is really something for urban areas and for kids who don't have access to bottled water and fluoride. So I think it's fantastic, but I'm always shocked when people think that dentists have some kind of ulterior motive in wanting to get fluoride in water. If anything, it's kind of putting ourselves out of business a little bit, because there's going to be less decay in children's mouths. And I think most of us don't absolutely love working on kids. So we want to see the decay rate brought down in kids, and we just want to do crowns on their parents, you know, for more money and be able to do this. But dentistry, I think, always has its heart in the right place, trying to get fluoride into the water for the people who don't have access to regular dental appointments. And it drives me crazy when these anti-fluoride people think that there's some kind of ulterior motive or hidden agenda, or it's about political power. We're trying to do something good for the people who can't afford to go to the dentist.
Definitely.
Thank you, Megan, for those stories. Now, let's take a look at the case of the week. For this week's case of the week, I actually chose one of my own cases because I had a very interesting case come through our door a couple of months ago, actually, before we got started. And you can see here as we take a look at it, this is a patient who is suffering from some pretty severe tetracycline staining. As you look in there, you can kind of see the effects on all the teeth except for this one. And of course, the one crown that's been done here that kind of stands out like a sore thumb, an old PFM that looks very opaque at the same time. We've got some edge-to-edge bite issues over here on the patient's right-hand side. It gets a little bit better with the centrals, and then we're back into more of a proper occlusion over on the patient's left-hand side. But these are really tricky cases to deal with. I've tried doing them with no prep veneers. That doesn't work. The veneers are way too thin. I've tried them with minimal prep veneers, and that doesn't seem to work either. You still have bleed through of the color. And I've tried it with fully prepped veneers as well. And the problem is, as you start to prep into these teeth, you learn that the tetracycline is really in the dent, and by removing the enamel, the color gets more intense on the stump shade as you go deeper into the tooth. And so his sister, who also works here, was somebody who I worked on who had tetracycline staining. And we tried making 2 sets of veneers on her, a minimal prep set of veneers and then a fully prepped set of veneers. And neither of those worked. She wasn't happy with either, and so we ended up going with full crowns. And she's a technician, as is he, and so she was reluctant to go to full crowns, and we got there kind of a weird way by doing 2 sets of veneers first, but it was only then that she realized that to truly get the type of aesthetic change that she wanted, it was going to have to be crowns. And frankly, after we had done the normally prepped veneers the way I was taught at LVI back in the day, that's basically almost a crown prep anyway. We just really needed to prep the lingual surface at that point to make it a full crown. So I'm all for conservative dentistry. In fact, I vastly prefer minimal prep veneers over traditionally prepped veneers. But when we're trying, the only reason we're doing this is to try to get a nice aesthetic change. Sometimes our hand is forced towards crown. So this is the brother of that patient who saw what we went through with his sister case, because he made those restorations. And so at this point, he was ready to start and say, let's just do crowns, because their teeth were about the same shade. So you can see where we're starting and how dark they are. And so he was on board with crowns from the very beginning, because we both felt that was the only way we were going to really be able to get any kind of an aesthetic change. What I wanted to do was use some Bruxer crowns as well. We've seen before that sometimes we get bleed through of the stump shade on Emax and sometimes we don't, but we hadn't done a case like this yet with Bruxer. And this technician works in the Bruxer department, so he was happy to do it. So we're going to actually do Bruxer crowns on these teeth to see if we have any kind of show through of the preps once we're done. So we just start off by placing that PFG gel into his vestibule. This is, again, the super strong topical anesthetic that I use that gives great anesthesia. Patients simply cannot feel the needle piercing the mucosa. We put that on, we rinse it off. We don't leave it on any longer than about 45 to 60 seconds before we begin preparing the teeth. And then as part of the reverse preparation sequence, the very first thing we're going to do is break the contacts between the teeth. Now in this case, because we're prepping both teeth number 8 and 9, we're going to use the 856-025 burr to go in and break the contacts and start our interproximal margin formation at the same time. If we were, for example, only prepping teeth number 8 and 9, when we got to the distal of 9, between tooth number 9 and 10, we would just use a 55 burr so that we broke the contact just by prepping the distal of number 9. But anytime we're prepping the 2 adjacent teeth, I just skip that 55 burr. We're going to go right to that 856-025 burr, my favorite burr, and go in there and break the contact and start our interproximal margin formation at the same time. Once we do that and we break that contact, then we can go ahead and put that first cord in, that 00 cord. But I actually don't have any intention of taking the impression today by the end of this. But the cord being in place helps us kind of dial in where to put the margin. Now, as the next step of the reverse preparation technique, you can see this 801-021 burr. This is probably a burr you're not completely familiar with. It's a round diamond. And the one time that I use it is for the gingival reduction when I'm doing this reverse preparation technique. And you can see how nicely it does two things. We've accomplished two great things here. We've got adequate reduction in the gingival third, and the other thing that we've done is given ourselves a head start on forming the gingival margin. In fact, it's almost completely done. When we do the axial reduction on the rest of the tooth here, we're going to be left with a quarter circle, a deep 1 millimeter quarter circle at the gingival margin. And that's kind of the perfect deep chamfer, shallow shoulder, whatever you want to call it. We want to make sure we have enough thickness here so that we don't have the stump shade of the tetracycline teeth showing through. In fact, when we struggled with his sister, with those two sets of veneers, where we struggled the most was in the gingival third, where the material, the restorative material, was the thinnest, and that's where we really had a lot of show through. The incisal edge wasn't that bad. So we want to make sure, even though we can be more conservative with Bruxer, in a case like this, we want to make sure that we don't see the underlying tooth showing through. We're going to go ahead and do our regular reduction with the 801-021 burr, as if this was going to be a lava crown or an Emax crown or a PFM crown. But you can see how nicely that depth cut and that margin formation starts with that round burr. It's kind of the key to the technique. And of course, this is another key to the technique as well. The reason I started doing this prep technique is so I wouldn't have to guess anymore about how much I've reduced. And you can see as we go in here and put a 2 millimeter depth cut in here, you can see how this depth cutter is self-limiting. It can't go any deeper than the little shoulder right here. And by the time I put 2 or 3 little 2 millimeter depth cuts in here, it's very easy just to go in and blend the 3 of those and have a nice 2 millimeter reduction. When I started practicing here at the lab 12 years ago, that was the one complaint that I got from the technicians all the time is, you gotta give us more room. Why aren't you able to see what 2 millimeters of occlusal or incisal reduction looks like? And that's when I started looking around and found these depth cutting burrs from Access Dental so that I could be sure when I gave them a case that there was 2 millimeters of incisal reduction. And I don't get the technicians coming up to me asking for more room anymore, because now I'm giving them what every laboratory and every ceramic manufacturer has been asking for and recommending for years, 1.5 to 2 millimeters of incisal or occlusal reduction. So at this point, as we look at this picture, you can see that we've got the depth cuts in the gingival thirds of all the teeth. So we've got 1 millimeter of reduction there, and we've got the beginning of our margin. You can see that we've got our incisal edge depth cuts into all those teeth as well. And you can also see at the junction of the incisal third and the middle third that we have our axial depth cut. And so now really all we have to do is take that favorite burr of mine, that 856-025, that big fat one you saw in the beginning, and now is the fun part, because we can just fly through this preparation. I'm not saying we don't pay attention, but I'm saying that we don't have to stop and check our reduction at any point. We know because of these depth cuts we're as deep as we need to be, and so you can prep very quickly because you know exactly where you're going now. There's a roadmap that's unfolded in front of you in terms of these depth cuts, and now we know exactly where we need to go, and we just need to make all those depth cuts go away. So you spend a little extra time in the beginning on the front third of the prep sequence putting these little depth cuts in, but now you can just fly. Now there's, the depth cuts will tell you where to go and will help shape the preparations for you, and that's what I like at this point, is that all the guessing has been removed. There's literally no guessing at this point. And so about 30 minutes later, we end up with those teeth being all prepared. And again, because of the depth cuts, because I'm able to use those to reduce enough tooth, the preps just end up looking like they're supposed to look. Not because I've all of a sudden grown an artistic set of hands and I can now shape these types of preparations from the teeth. That's really not it. I just remove all the depth cuts and this is what is left over, and it just happens to be the shape of an ideal prep for this. And as I mentioned earlier, you can see some of the areas on the dentin where the teeth are definitely darker than they are in some other ones. You can see that on tooth number 8 we've got some real dark tooth structure almost all the way to the cervical third. Number 9's got it all the way to the cervical third. Some of the other teeth are dark, but not as dark in the cervical third. Maybe that had to do with where they were in terms of mineralization, in terms of the patient's age when he was taking the tetracycline. So at this point, because I've learned that on these anterior aesthetic cases, that the one thing that used to bite me in the butt all the time was trying to take the impression on this day and then deliver the restorations at the next appointment. I slow down now on these large anterior cases, and today I'm just going to reline the biotemps and put them onto these preparations, then have the patient back in about a week and a half, and we'll finish any little preparation refinement we need, pack the cords, take the impressions, and being able to put the biotemps back on, because sometimes the biotemps will cause tissue levels to move and we need to adjust the prep. And I want to be able to know what my biotemps are going to do to the tissue when they're on these teeth. And I need that extra appointment to be able to do that. I need to be able to put the biotemps on at this appointment and be disciplined and patient enough to take the master impression at the next appointment, knowing that it's going to save me a bunch of time when I go to seat them, and I'm going to end up with some really nice fitting restorations, especially at the gingival third, at the interface between the restoration and the gingiva itself. So my goal today at this point is just to get those biotemps on. And this is actually going to be from a video we're editing right now. It'll be available on the Glidewell website under the clinical videos, and you'll be able to watch this entire case start to finish. And you can see the restorations that we have here on the end. And really this is just what I wanted to show you today, is that, you know, I've kind of found another use for bruxer restorations. And this happens to be for anterior bruxer restorations. Most dentists understand why you would use bruxer in the posterior because of its high strength. It's able to go places where other tooth-colored crowns can't go, like lower second molars. It's actually able to function as a cast gold replacement when you want to do cast gold and the patient doesn't want to do it. And dentists at my lectures will often raise their hand and say, well, why would I do bruxer on anterior teeth? And a lot of times I say, you know, I'm not sure. You may want to just use Emax unless the patient has broken previous ceramic restorations or shows a lot of wear on their anterior teeth. And then when this case came in, I realized, well, here's another reason why we might want to do anterior bruxer restorations. You'll notice that we cannot see any of that tetracycline stump shade showing through those crowns at all. I really don't think I could see any. If I could see a little bit, I would tell you about it and point it out. But this material does a good job of blocking out underlying tooth structure while continuing to be, I should say, translucent enough to still be aesthetic. Now, it's not going to show the kind of transparency that Empress or Emax does, but we continue to work on it and continue to improve it. But the good news is, if you've got one of these dark tetracycline cases, and again, all you have to do is look at these lower teeth to remember what those upper one looked at. In this case, bruxer shows that it can be a very good restoration for blocking out that color and giving a patient a more highly desirable aesthetic result on teeth like that. The patient wants to go ahead and do the lower ones next year, and so he'll probably be able to replace all of that look on his teeth, so when he speaks or smiles, you won't be able to see those dark tetracycline stains anymore. So of course it's helped, bruxer's helped here by the fact that all these units, that all 10 of these units are next to each other, and we're not trying to match it to a natural tooth. My point being, I wanted to share with you that I feel like I found another good indication for anterior bruxer restorations when we're trying to improve the aesthetics of somebody who's got a very deep tetracycline staining. That about wraps it up for this week's edition of Chairside Live. Megan, you had a week off. Did you feel rusty at all today? Or
I did. I feel like I'm still trying to get back into the swing of things.
So it was more your B or C game than your A game?
Right. I definitely, that was not A game. Nope,
right,
not a chance.
I enjoyed it. We're back on the horse again, and we've got a couple solid weeks coming up where we'll get a chance to do this. On behalf of myself, Megan, and everybody here at the laboratory, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time.
I remember in dental school, they told us we're only going to tell you one question that's going to be on the test tomorrow, and it's going to be, you have to spell fluoride correctly, because everybody wants to spell it flour,
right.
F-L-O-U-R instead of F-L-U-O-R.
Yeah. And
I got every other question right on the test except for that one. I spelled it wrong.
Come on.
So that word torments me as I'm staring at it. I'm getting angry. Well, go ahead. Let's do the story anyway.
All right.